she has done trials and also conducted a few meta-analysis. Dr. Swagata, over to you.
Thank you so much, Dr. Deva. That was very kind of you. And I thank the SNCC, Dr. Prashant, Dr. Deva, everybody there for giving me this opportunity. I'll share my screen. And as Dr. Deva correctly said, yes, is my screen visible?
Yes, it is.
Perfect. I just wanted to... Right. So I will not be able to see any queries or questions that come up. So I leave that to panelists. So as Dr. Deva said, this is a topic which is of close interest, renewed interest for me, and I thank everybody for allowing me this opportunity. What we will be speaking about in the next 20 to 25 minutes is looking at the evidence that exists for the use of beta blockers in traumatic brain injury. Yeah. So we are all aware that traumatic brain injury is a major cause of mortality and disability the world over. And most importantly, in middle income countries, even more in the Indian subcontinent. We are known as the trauma capital of the entire world. And unfortunately, the damage that traumatic brain injury does to our socioeconomic fiber is much greater than the rest of the world. It affects patients who are of at least a decade or two less in age than that which occurs in the West. So it is a productive population and predominantly male population in a male-dominated society that gets affected by TBI. And therefore, it is of great interest to see what are the things that can affect and improve the outcomes in this category of patients. For quite some time now, beta blockers have been proposed to improve outcomes in TBI patients. Most of this evidence, as we shall see, comes from the West. And by its very nature of coming from the West, it relates to patients who are older, like I just said. And patients being older are very often already on background beta blockers. So the evidence that we have from the Western studies, more often than not, retrospective observational studies, has looked at these patients who are older, who were on background beta blockers, but they have seen that these patients have surprisingly better outcomes, especially mortality-wise, than patients who were never on beta blockers. Today, this talk, we will synthesize the clinical data on the beta blockers in acute TBI, and we will focus not only on mortality, but also on the functional outcomes of the patients. So to do this, and to do this more systematically, and perhaps so that it helps some of the students who might be us, I want to talk about this particular meta-analysis and take us through the evidence via this meta-analysis so that the understanding is a little easier than discussing the results in a vague manner. So this is the most recent meta-analysis that we have, beta blockers and traumatic brain injury, published in Trauma, Surgery and Acute Care, and the first author is Shannon Hart. Interestingly, in the same year, in another journal, there was another systematic review and meta-analysis published for the same topic, beta blockers and traumatic brain injury. However, we chose this one because this has included 17 studies as against 12 in the other one, the one by Zagalis et al. A little bit of the background. Traumatic brain injury, or any brain injury for that matter, we know, affects the entire organ system of the body. Through cellular and humoral responses, it affects the inflammatory system. It messes with the sympathetic parasympathetic balance in the body and causes an acute catecholamine surge, also known as the catecholamine storm. All these things will affect organs all over the body, the brain-heart axis, the brain-kidney axis, the brain-lung axis, and the brain-gut axis have recently become catchphrases, and I'm sure all of us are aware of it. So the very basis of considering beta blockers rests on this knowledge that the brain affects the whole body through these catecholamines, indigenous catecholamines act through beta receptors over the body. So the hypothesis is that if we can block these receptors, perhaps the end organ damage that we are assuming occurs as a result of this would come down. Now, you might say, what is new in this? We have always been using beta blockers for the paroxysmal sympathetic hyperactivity that we see in patients, and you would be right. The difference here is that paroxysmal sympathetic hyperactivity, as we all know, starts a few days into the injury. And perhaps it is just that it is a severe manifestation, clinically very overt, very disturbing. And that is when we just treat the symptoms because they've started occurring. The concept of using beta blockers in traumatic brain injury preemptively starts with the thought that can we prevent the injury before it occurs? So if we had some idea about beta blockers, why was this meta-analysis that we're talking about needed? We know that the use of beta blockers has been investigated for years, and we shall see starting 2000, it has almost become fashionable to look at it. And in these studies, beta blockers have shown a mortality benefit. Among the beta blockers, we also have a fairly good idea that it is propranolol that has the best evidence. The reason why propranolol is preferred over the other beta blockers depends on its pharmacokinetic and pharmacodynamic properties. It is much more lipid soluble than the other beta blockers. Therefore, the permeability into the brain, blood-brain barrier is better. The availability inside the brain is much more. Apart from that, it is a non-selective beta blocker, has also got some actions on the alpha receptors, and therefore the effects have been seen to be a little different. And the side effect profile is better than that of the other non-selective beta blockers that we know, the sotalol, timolol, and the others that are present. So propranolol, kind of, it is understood, is the drug we're talking about when we talk about beta blockers and traumatic brain injury. So all this we know. But there is a lack of consensus on the effect of beta blockers on the functional outcome of patients. So all the students would know about the DECRA trial and the other trials where there is now a big, almost moral controversy or a discussion about, is it enough to just get our traumatic brain injury patients living more, or do we want them to live better? In fact, perhaps it may be unethical to get people to live more if they have a poor quality of life. So the surge of interest now lies on what beta blockers do to the functional outcomes of our patients. And we all understand that there is more need for more rigorous analysis and quality assessment of the available evidence that is there with us. Like we said, even in 2023, one meta-analysis looked at 12 papers, whereas the other one found 17 papers to look at. And then again, I must again point out that the evidence from LMICs is extremely poor. We need more evidence from here, not only because our patient population is less, but because the evidence that is coming from these studies from the West also raise some concerns of how this will act in our scenarios, as we shall see in the slides to come. So coming back to the meta-analysis by Hart and al., we'll now look at what they did and finally talk a little bit about studies that are there after 2022, this meta-analysis, and where else beta blockers are being used. So Hart and al. Did a comprehensive search across Medline. They looked at 3 databases, also Embase and the Cochrane Central. They looked at studies up till 2022 February. 2 independent reviewers selected the studies, and the discrepancies between the studies were resolved by a third reviewer, as is usually the norm in any systematic review and meta-analysis. And the quality of evidence was assessed using the grade approach. What was the data that they extracted? Of course, they looked at what the study characteristics were, which country the studies emerged from, what were the demographics of the patients which were included in these studies, what was the type and dose of the beta blocker that was administered in these studies, what was the mortality, and if available, the functional outcomes of the patients in these studies. How many of these patients required surgical intervention? Because remember, among all these various studies, it was a mixed population of how many patients were getting invasive ICP monitoring, and there was many patients who were not getting ICP monitored. So surgical intervention was looked at. The Glasgow Coma Scale at presentation, the number of patients who had blunt trauma injury versus penetrating injury. They also looked at whether the patient had isolated brain injury or there was an overall whole body injury. Usually when you have patients with mass trauma, head injury is only a part of that. So the other organs are also involved, other parts of the body are involved. So they looked at the injury severity score because that would affect the mortality and the functional outcomes at the end. And finally, they looked at cardiopulmonary and infectious complications between the groups in these studies. Statistical analysis, I'll just keep this short, but for any meta-analysis, you would have to choose a model. They did a pairwise meta-analysis and chose the random effects model for all the outcomes. You usually choose a random effects model when you are already aware or you find out that the studies are very heterogeneous. The patient populations are very heterogeneous, the size, the kind of patients, the kind of drugs, which is true for our meta-analysis. And therefore, the random effects model was chosen. The weights that each study would attribute to the final analysis calculated using the Mantel-Haenszel method. The pooled fit estimates were obtained for continuous variables. They looked at mean difference in the outcomes. And for dichotomous variables, they looked at risk ratios. Heterogeneity was set in the I-stick, and an I-square greater than 50% was considered to represent considerable heterogeneity. And they set out the p-value of less than 0.05 to be statistically significant from the start. 17 studies ended up being included in this meta-analysis, as I told you. There were 3 types of studies that were there. There were 2 which were prospective. There were only 2 randomized controlled trials, and the majority of them were retrospective studies. Out of them, only 1 study, which was a randomized controlled trial, it came from a low middle income country. Others were all from the Western developed world or the high income countries, so to speak. So among these 17 studies, and you see the flow, the Prisma flow over here on the left, starting with 8560 studies, we ended up with these 17 studies. And why articles were excluded, the reasons are there as it should be in the Prisma diagram. Among these, 4,500 odd patients had received beta blockers, and more than 8,700 had not received beta blockers. Like I said, the focus of these studies were very different. Some were examining specific dosing. There were some studies which included a patient in the beta blocker group if he got or they got even 1 dose of beta blocker. So a single dose in the entire hospital stay, and they included the patients in the beta blocker group. So you can understand how that would affect the results of these studies. They included patients with different types of injuries also, like I just said. Some of them excluded penetrating injuries to the head, some did not. And the interventions were also different within the studies. Of course, the studies were selected through a systematic search, and there was an independent evaluation, as in any good systematic review. So we will look at this slide is just a synopsis. We will look at each of the results in detail, but what the meta-analysis of these 17 studies found that the beta blockers reduced mortality. There was no mortality difference if the patients were getting beta blockers beforehand versus afterhand. There was no difference in functional outcomes at discharge, but there was a benefit seen when you followed up these patients for 3 months or 6 months or 12 months. And beta blockers increased cardiopulmonary complications and also infectious complications. So it is this last component which is of concern for countries like India, the infectious complications being more in patients when they get beta blockers. So this is the table that the authors have provided to us that gives us the characteristics of the included studies in the meta-analysis. The authors are arranged alphabetically. So you can see that the years are mixed and matched. I have highlighted the two randomized controlled trials that are available to us, the one by Khalili et al. In 2020 and Tropel et al. In 2019. Note that Tropel et al. Have actually been working on this topic since 2010. And after two large retrospective trials, this study is more like a pilot study, the randomized controlled trial, which will lead to a larger randomized controlled trial. The other things that I would like you to see are the age of the patients included in this study. And immediately this Khalili et al., which I said is the one RCT, which is a low middle income country, is 37 plus minus 17 versus you can compare it with a lot of other studies which are much more than that. The percentage of male patients is again varies across the patient across the group, and there is a difference in how many patients had penetrating injuries, what kind of interventions there were across all these studies. Now we look at the results that I've already synopsized to you initially. So the four main results, which I have put on the right, and the forest plots for them appear on this slide. The first one tells you about the pooled in-hospital overall mortality among patients. A short points about reading a forest plot. Again, you have the names of the authors on the left. Then they'll tell you what were the two groups, beta blocker and the control, and what percentage of patients belong to which. Then there is the weight that is afforded by each of the studies into this pooled analysis. So a better study, a larger study, a less heterogeneous study will probably lend a bigger weight. And the more the weight, the bigger will be the square size of the square on this forest plot over here. And finally, the risk ratio, the relative risk with the 95% confidence interval is available on this. What we look at and what we are interested in is the pooled estimate of the mortality in the first A graph. So in this graph, we see that after pooling the results, we found a 76% heterogeneity, which is quite significant, but the relative risk was 0.82, and the confidence interval did not include 1, which resulted in the diamond being on the left side of 1, or a significant result. A 0.8 relative risk means that beta blockers reduced the risk of death by 20% as compared to the controls. So this is the first result that we got. Look at the mortality in the pre and post admissions beta blocker. So this is a subgroup analysis. There was a comparison between patients who were only getting beta blockers post-injury, those studies that reported it, and the studies that reported patients who received both pre and post-injury beta blocker. So the studies above, they were excluding patients. It was in their exclusion criteria. If somebody had got or had a history of receiving beta blockers before the injury, they would exclude these patients. Whereas the lower studies over here, they would not exclude patients who were getting beta blockers before the injury. So when they did a subgroup analysis, like you can see the diamond over here, it was not significant. And again, it was very heterogeneous. So there was no difference whether you got the beta blockers before and after. Looking at the in-hospital mortality, only for propranolol, again, the diamond is quite flat. So the confidence intervals are quite large and it is non-significant. But when you look at in-hospital mortality after segregating for the kind of the traumatic brain injury you have, you can see that for blunt trauma injury cases, the small box here is fat, short, and towards the left of 1. So the relative risk is 0.82, again a 20% reduction with an I-square of only 12%. So what this tells us is that beta blockers in this meta-analysis reduced overall mortality, but only more significantly and more believably in those cases who had blunt trauma injury to the brain. Post-injury initiation did not show a clear mortality benefit, and propranolol had mixed results, which warranted further study. The other results that are there in this paper are those comparing functional outcome using beta blockers at discharge and at long term after discharge, so 6 months follow-up. As you can see to the left, very few studies have actually reported long-term outcomes. So at hospital outcomes, 3 studies, long-term outcomes, 2 studies. So when you look at the graph, the forest plot again, it's very clear that short-term outcomes or at discharge functional outcomes do not differ between the 2 groups within the studies that are included in this meta-analysis. However, at more than 6 months, when it was looked at, it was seen that the outcomes of the patients who got beta blocker, favors beta blocker, was better than those who were not getting beta blockers. Similarly, when you look at the complications associated with the use of beta blockers and compare it to patients who were not getting any drugs or getting placebos, you can see the cardiovascular, both the cardiovascular complication, which is the graph A, and the infectious complications, which is graph B, are towards the right of the one center, which means it is clinically significant. In fact, a 1.94 relative risk tells you that there is almost a double risk of cardiovascular complications in patients who get beta blockers. And if you see the heterogeneity, it is 0%. So this is a strong, believable outcome that cardiovascular complications are more in patients who have beta blockers. And although we see that complications of infections are also more, it's towards the right, for those patients who got beta blockers, we can see the diamond is flattened and it is stretched out, and the heterogeneity is very high. So how much we can believe on this data is left to interpretation. So again, in short, the beta blockers perhaps do not result in early functional improvement, but long-term benefits exist. And the low heterogeneity in the long-term results increases the confidence in the findings in the first panel of results that you can see. And in the second panel, the beta blockers increase the risk of cardiopulmonary and infectious complications, but the high heterogeneity in the infectious complications suggests variability in patient factors or the definitions that were used to call an infection, for example. Right. So this slide now kind of brings all the results of this meta-analysis together, and it compares the beta blockers with placebo in traumatic brain injury. And as you can see, for inpatients who were getting beta blockers and compared to placebo or no treatment, we have looked at 4 major outcomes: mortality, good functional outcome, cardiopulmonary complications, and infectious complications. And as we just saw, we have discussed the results in detail, what was the relative effect and the 95% confidence interval. We can see for mortality, the number of the percentage of the studies and the population that was contributing to this result was very high. But as for the other results, the populations rapidly dwindled down. And the certainty of the evidence as accorded by the grade classification for all these outcomes is low to very low, because mostly for the substantial heterogeneity and the fact that the majority of the studies were retrospective studies. So coming to what were the limitations that the authors put forth for their meta-analysis and why they sent out a call that better evidence was needed. As we all saw, majority of the studies were retrospective cohort analysis, and this limited drawing conclusions that were definitive. Only 2 randomized control trials were included, and we all know that RCTs are the best grade of evidence, but both of these RCTs were unblinded and the sample sizes were small. The reason that both these studies give for being unblinded is mainly because of course, the difficulty and the extra funding required and the complexity of making a blinded study. That apart, they also said that given the fact that the effects of beta blockers are quite obvious, it may not serve a purpose to blind these patients. So if you're giving a drug that consistently keeps a heart rate between 70 to 80, it's quite visible to the clinician that this patient is in the beta blocker group. So this is just to tell why these studies have been, two RCTs have been unblinded. Then the complications, like we saw, were not reported commonly across all the studies, and only few studies were providing detailed data on these adverse effects. The definitions were different, and when we hear that cardiovascular complications were double that in patients who were not getting beta blockers, please keep in mind that we are talking about a cardiovascular complication can be anything like a heart rate less than 60 for more than 5 minutes. So they were taking those down as cardiovascular complications, or requirement of starting off noradrenaline, for example. But in neuro patients, traumatic brain injury patients, we know that many times we are starting vasopressors to push up the MAP. So it may not be directly related to the beta blockers in the first case. And that is why this is a limitation of the meta-analysis that requires greater in-depth study. The overall quality of evidence rated was very low, highlighting the need for high-quality randomized controlled trials. So conclusions and recommendations: beta blockers have been associated with reduced mortality, and at least till now, there is, even if the evidence is less, it has shown some improved long-term outcomes that makes it very attractive. However, increased complications have been noted, necessitating careful risk-benefit analysis, especially in countries like ours, with the increasing scourge of multi-drug resistant organisms. If we are using it left and right without evidence on our patient population, we might actually harm our patients. Low quality evidence limits definitive recommendations, and large high quality randomized control trials are needed to establish clear clinical guidelines. So with that, I'm nearing the end of this discussion here today. And I just wanted to cover this one protocol that I found when I was looking for what else has been happening in this area after the meta-analysis was published. So in the year 2021, Meniar et al. Have published this beta blocker use in traumatic brain injury protocol, which is the BBT. And here they have the background and the reason for the study is what we've already discussed. But the new thing that they have introduced in this study protocol is that they want to use high sensitive troponin values to segregate the patients into those who have actually started getting a high sympathetic surge that leads to the cardiac events and leads to a troponin sensitive positivity, and see whether propranolol improves their outcomes more versus patients who probably don't have a high catecholamine storm in the beginning. So basically, this is an attempt to individualize patient selection and to see if the treatment, if you can selectively pinpoint that cohort of patients within the traumatic brain injury who would perhaps benefit more from having beta blockade. So this is the, like I said, they had planned that they would immediately do a high sensitivity troponin test. And for those that it was positive, everybody gets the propranolol for 6 days. They aim at a heart rate more than 70. So all of these studies just go on increasing the dose till you get a consistently stable heart rate of around 70 to 80 without causing hypotension. And for that patient group that comes high sensitivity troponin negative, what you do is you randomize them into two groups. One of them gets placebo and the other one also gets propranolol. So at the end, you will find out whether you even need to do the high sensitivity troponin test or not, or if you're doing it, will it be beneficial? Because of course there are costs involved to it. So this is the protocol that's out there on trials. However, the results of this study are not out. The sample size they found was more than 700 patients. So I guess they're still recruiting. And the final slide, just to bring things back to perspective, I am a neuro and a general intensivist. Beta blockers are of interest to the entire critical care community. And the drug is relatively safe all the drugs for that matter. Their use is titrable. They're available in oral forms, they're available in intravenous forms, they're available in very short-acting formulations, they're available in long-acting formulations. So the interest in using beta blockers has really gone up all over the critical care community. And these two studies just show the other areas which are being explored. So the recent publication in Critical Care Medicine looks at propranolol as an anxiolytic to reduce the use of sedatives for critically ill adults who were receiving mechanical ventilation. Again, it was an open label randomized control trial. We did not have a placebo group. Similar reasons given. This is a very interesting study which recruited patients during the COVID pandemic where they ran out of sedatives really. So because they did not have enough midazolam and propofol, they wanted to look at the effect of beta blockers and see whether that would reduce the requirement of sedatives in this patient population. You can go and have a look at the entire study. But interestingly, it was a positive study and there was a significant reduction in the requirement of sedatives for patients who were getting beta blockers. I think it's quite intuitive because many times we give the sedatives when there is a high heart rate, high blood pressure. So if you're giving something that kind of tempers down these vital statistics, we would not unnecessarily give these sedatives. Of course, the moment they had to paralyze these patients, the patient would not get propranolol anymore because then you don't want to paralyze patients and have them have a low heart rate and low blood pressure with them being aware and without sedatives. So that was the first study that I thought would be of interest to the audience here. And the second one, of course, is the landiolol study, a very popular study in JAMA. And they looked at intravenous beta blockade with landiolol for sepsis. So sepsis is one area where beta blockers are being studied very actively. And this is one of the reasons why I personally am a little skeptic about the increased infections seen with beta blockers in traumatic brain injury patients. So on one hand, if beta blockers decrease infections and sepsis and improve outcomes, or at least there is a hypothesis saying that, why would they increase infections in traumatic brain injury patients? However, this study, which used landiolol, was a negative study. It did not show an improved outcome in the patients. So with that, I come to my last slide, which is watch this space. Beta blockers are an interesting drug. What really happens and how they make an entry into the guidelines or not remains to be seen. With that, I will end my talk and stop sharing my screen. Thank you so much.
Thank you, Swagata, for that excellent overview on how beta blockers are, how they work. They are helpful in traumatic brain injury, and thanks for taking us through all the available evidence there is. Are there any questions from the audience? You can unmute and ask, or you can type it in the chat box. I'll read it out for you. Any comments from any of the audience? There seems to be a silence. Swagata, I've got a question, and I'm going to ask. As an intensivist who looks after both general and trauma patients, we don't use beta blockers so much in our unit. And although I have to say, off late, I've started using propranolol only for those, TBI cases where I see sympathetic storm as a problem. Not for all TBI patients. And I know it's only a few handful of patients, a few patients. I did not face any major problems with respect to, bradycardia, hypotension, etc. But like, what proportion of patients get these cardiovascular complications? Any ideas?
So in the studies that we have seen, in this meta-analysis or even the two RCTs, the proportion is less than 5%, and the complications we are looking at are pretty what we wouldn't call complications in the ICU really. So like I said, because it's a study that's been done with a protocol in place, so even a single episode of a heart rate of less than 60 is called a complication. The ones they try to look for is a new start of a vasopressor or a new onset block, cardiac, so that is very, very rare, really.
It is quite interesting because you also put up the general intensive care evidence as well. Despite the fact that the landiolol study was a negative study, the most I don't know whether anyone has seen the most recent Japanese sepsis guidelines. It clearly says consider using heart rate controlling medications in patients who are tachycardic despite fluid resuscitation and vasopressor administration. So although the evidence is not all that strong, already some of the organizations are recommending this in their guidelines. There is one question in the chat box. The mechanism of infection, increased risk of infection due to beta blockers?
Right. So I will not be able to answer that because that's really not known. Like I said, it's a query why it happens. It was an incidental finding more than anything else. But I suspect that traumatic brain injury patients already as a effect of their injuries are immunocompromised. We know that. That's the brain immuno axis that we were talking about. So that it's possible that that's what we are seeing. But why the difference, I will not be able to say. There is another question. What do you recommend? What dose do you recommend, and from when to start from all these studies? Right, great. So I'll be able to answer that one. So most of these studies look at starting the 20 milligrams TDS or QID. One study has started BD, but anywhere between 3 to 4 times a day, start with 20 milligrams enterally. Some studies have given IV esmolol as well, but the two randomized control trials look at propranolol given orally, enterally, 20 mg TDS. And then they increase the dose looking at the endpoint of the heart rate. If as long as the heart rate stays between 70 to 80, they will go on increasing dose. They have gone up to a maximum dose of 100 to 140 mg given TDS. So 420 mg total is the maximum dose that has been seen. And they start as soon as possible. So the moment they get the patient, they're starting, and most of them continue this till 10 days or 14 days after the patient comes to them, because that has been recognized as the time period with the maximum sympathetic surge. So that was one question. Then, which severity of TBI patients had mortality and long-term benefit? The mortality benefit was seen to be more concentrated in patients with a more severe traumatic brain injury, so GCS less than 8, but long-term benefit did not see this difference so much. Beta blocker and increased risk of stroke in these studies. I'm not sure that these studies have actually looked at increased risk of stroke. So, I mean, I know that they haven't. So I'm not sure I understand this question. If probably you could elaborate on that. Dr. Babu is asking, yes, he has a comment. Dr. Babu, I can't, wait, please speak. You can unmute yourself. Would you like to? Deva, do you want to take that comment? No, I think. Okay.
Hi, Dr. Babu. So to comment on your question, most TBA patients are sedated of ICD, and drugs used usually takes care of the catecholamine surge. So the patients who require beta blockers may be very small. Yeah. Yes, Dr. Babu, but despite the sedation, some patients do have the sympathetic surge, significant sympathetic surge. Just like I'm sure you know, just like how we see in the subarachnoid patients, you do get the patients who become really tachycardic, and the surge is uncontrolled by the sedation. In such patients, the propranolol may be helpful. That was the theory, and as Swagata put up. I don't know whether it is worth looking at troponin as a marker to individualize the beta blocker administration. I don't know. I mean, you can also comment on that. And Swagata, what do you think about that comment?
Yeah, I agree with what you said, Deva. And the very mechanism of action by which the sedatives decrease the heart rate blood pressure is very different from blocking the receptors, the end receptors. So that is the hypothesis as to how the effect might be there, the benefits might come. Because with the sedatives, you are not really decreasing the sympathetic drive, you're just decreasing the awareness and the other centers of the brain more than that of the end effect receptors. So that is one thing. And Shalini, how soon is the high specific troponin being tested? Um, I will not be able to give you the specific number there, so probably we'll have to look at the protocol again. But again, I mean, all the studies do these first three steps as soon as they recruit the patient. But the window for recruitment, I'm not sure for this in this study.
I think it's 1 hour and 3 hours or under 3 hours. I mean, all
Okay.
the high sensitivity troponins do 1 hour. I think same in this study as well, under 3 hours.
Yeah, perhaps. And they do discuss the fact that it won't be very easy to find out whether it's the origin is cardiac or the origin is just the sympathetic surge affecting the cardiac muscles. So yeah.
Are there any other questions or comments? Okay, if there are no further questions, can we wind up the session? Thank you very much, Dr. Swagata, for that wonderful and insightful session on this evolving topic. Hopefully, your BBTBI, that's BBTBI, right? So BBTBI trial would put an end to this, debate whether to use or not to use propranolol in TBI. Good luck with the trial. Thank you very much. On behalf of SNCC, I thank you for agreeing to share your thoughts and knowledge on this particular topic. Thank you.
Thank you so much, everyone. Thank you, Dr. Deva, Dr. Prashant, all the listeners. Really kind of you. Have a good night.
Have a good night. Thank you.